just a little refresher, this is showing you on a scale of where we like to be. We like to be between 735 to 745, and we accomplish this by having 20 bicarbs to 1 carbonic acid. When this is not the case, then our ratio is not maintained and our pH will fall out of normal range. Alright, looking at this, this is what I want you guys to do. I want you to look at the numbers and I want you to draw arrows. So look, we have a pH of 746. We know that that's elevated. We have a, so automatically, what are you going to call this? An elevated pH is alkalosis, right? Then we have a PCO2 of 30. That's low. It's supposed to be 35 to 45. And we're going to just stop there and we're going to label this as a respiratory alkalosis. Because see, our arrows are going in opposite directions. We're not going to pay attention to the bicarb at this time, but what's happening is the fact that the body's trying to compensate. So this patient has a respiratory alkalosis, but look, they're also hypoxic. So take a minute, look at this, pH 736, PCO2 29, bicarb 20. So when you look at that, you automatically realize, hey, this is acidosis. So what's my primary disturbance? I know we have acidosis. I look at the PCO2 and it's 29. That's going down. Mrs. Stiefvater said that if the primary issue was respiratory, my arrows would go in opposite direction. So this is not a primary respiratory acidosis because look, my arrows are not going in opposite direction. So I move on down and I look at the bicarb. The bicarb is going down. I remember that when it's a primary disturbance, that in metabolic issues, the arrows go in the same direction. And so here we have a primary metabolic acidosis. So here we have a pH, well, let's not do this one. This one's a little bit more advanced. It's an example of compensated. So we are not going to do this one. Okay, so looking at this, we're going to draw arrows. We have a pH of 7.21. That's low. We have a PaO2 of 93. Hey, that's good. We have a PCO2 of 32. Remember, it's 35 to 45. That's low. We have a bicarb of 17. That's low. I'm going through Rome. Respiratory opposite. My pH and my PCO2 are not opposite. Metabolic equal. Okay. My pH and my bicarb are going in the same direction. So I have acidosis and my primary disturbance is metabolic. Let's talk about this slide. Someone comes in, heroin overdose, drug overdose, only breathing 5 to 6 times per minute. Think about that. Stop and think about breathing that slow. And if you're breathing that slow, what are you not going to excrete? Okay? What are you not going to excrete? And so, in this particular case, yes, your patient's going to become acidotic. Yes, your PCO2 is going to become elevated because they are not blowing off CO2. And yes, their skin is going to be warm and flushed. And this brings me to a nice chart that's in your book on page 304. In this particular course in MP2, we do chronic. And so we're focusing, for instance, on tuberculosis is coming up, COPD, and asthma. And when you look at the primary disturbance of respiratory acidosis, it shows you on table 1710, so on page 304, page 1710, it shows you that respiratory acidosis is often the result of, for instance, COPD, or an overdose. So COPD or an overdose. And so this is an example of what happens to an individual and the signs and symptoms that they would have. So if you look further down on that chart, 1710, then what you realize is that we have someone who's undergoing gastric decompression. In other words, we're clearing out their stomach. They've got an NG tube in, and we're sucking everything out for whatever reason. What type of acid-base balance would this follow? And so if you go down to where it says metabolic alkalosis, you can see, for instance, the second example is excessive gastric suctioning. And so when we talk about GI later in the semester, you'll realize that these particular individuals are at risk for suffering from metabolic alkalosis. This is a question. A patient undergoing mechanical ventilation following a severe chest wall injury and flailed chest complains of chest tightness and anxiety and feeling as though she cannot get enough air. She's afraid she's having a heart attack. The nurse should first do which of the following? Thinking about that question, administer an analgesic, contact respiratory therapy to change the ventilator settings, obtain arterial blood gases, or notify the physician. And it would be obtain arterial blood gases. We need to know what's going on. Why all of a sudden is there a change in this patient's status? All right, guys. I think I'm going to add a slide. Let me see if I can figure out how to add a slide. Okay, let me add a couple of blood gases, okay? You guys can do them. Make them easy. pH 7.30. PCO2 57. Bicarb 24. SaO2 90%. Take a minute. Maybe even explain everything off and do this. So the pH is 730. That's low. The PCO2 is 57. That's high. The bicarb is 24. That's normal. The SAT is low. So what is our primary disturbance? We have a respiratory acidosis with hypoxia though too, because look, we have this. All right, let's do another one. So let's say the pH is 7.5. Okay, and let's say that the SaO2 is 96. And let's say that the bicarb is 30. And let's say the PCO2 is 40. So pH is elevated. Bicarb elevated. PCO2 normal. SaO2 normal. So what's our primary disturbance? We know we have an alkalosis, right? Our arrows are going the same direction. And the bicarb is the metabolic component.